So first of all, so the first thing is, let me talk about the new semen analysis. It's a very thick manual, which if you read from one end to the other end, it takes a lot of time and it also needs a lot of reading. So I'm summarizing it in 2 slides. WHO 2021 parameters are more than 15 million per ml, more than 42% motility, more than 4% morphology. It's quite close to what it was in 2010, but there are a few differences. We have shifted from the quantity to quality and function. See, earlier it used to be felt that you have a cutoff which at times was spoken of as normal. But now it is not normal. This is the cutoff of the 5th percentile. People above this may not get pregnant and people below this might not get pregnant, but this is a value of the 5th percentile. Now the second is, CASA has been put into as a standard interpretation, and sperm DNA fragmentation and oxidative stress, which earlier people did not bring into the previous manual, are a part of it now. Now let me talk about the clinical applications. It is low volume with absent fructose. Now supposing you get a report in which you have a volume of 0.3 ml and fructose is absent, it means either there is a vas aplasia or ejaculatory duct obstruction, chronic seminal vesiculitis, hypoplastic seminal vesicle, partial retrograde but fructose will be present, and urethral pouch or strictures, fructose will be present. Now if the motility is down, what will you think about? You'll think about, is it associated with oligospermia? It could be idiopathic, it could be infections, it could be antibodies. Now let's go on to, supposing there's a semen sample which has agglutination. So what all could it be? It could be infection, it could be antibodies, or it could be idiopathic. Now if there is altered liquefaction or viscosity, there can be either past or present infection or idiopathic. Now why do I bring this to you? I bring this to you because supposing you get a patient and this patient has agglutination or bad liquefaction, you've got to think in terms of the patient having an infection. However, something to understand is, I'll talk about the infection, then you'll really understand how important it is and what we confuse it with. Now comes total asthenozoospermia. Now you have all sperms, none of them are moving. So either you could have a microtubular defect, मतलब जिंदा है sperms पर हिल नहीं रहे, या मरे हुए sperm है जिसे हम नेक्रोस्पर्मिया बोलेंगे. कार्टिजिनस सिंड्रोम के अंदर भी वायबल sperm होते हैं but they don't move. Now let's come to the low count. Now a low count could be idiopathic. It can be a varicocele, gonotoxic factors, recent illness, relative gonadotropin deficiency, or partial obstruction. Now you'll ask me, why am I giving you this list? This actually is the most simplified thing which you can think about to actually plan your examination and investigation. Normally, I'll just talk about the examination. You would examine them thoroughly. So once you examine them thoroughly, then the question of you missing out something doesn't arise. But a few investigations are needed as per the semen report. Now, supposing you have a very large number of abnormal sperms, you'll check whether this has been checked by Kruger's criteria. You need a good lab to do this work. You got to see if there is gonotoxin exposure or it is intrinsic. Now, diagnostic testing for a male infertility patient. You would need some vital stainings. Now, these vital stainings are needed especially in those cases where you have necrospermia or very poor motility to see actually if these immotile sperms have life in them. Semen fructose you'd like to do to see whether it is an obstruction or not. Semen culture, of course, for infection. Anti-sperm antibodies if you find a poor motility. Now, peroxidase staining is very important. See, what happens is, whenever you see a sample and you see a lot of pus cells, or you report as pus cells, they may not be pus cells. They may actually be round cells or immature spermatocytes for which you need a peroxidase staining. And you need a biochemical analysis, which if needed, you could do. I'll just take a minute. There is just an important call. I'll just. So, now let me talk about the hormonal testing. So there are three basic hormones which are important. FSH. Just a minute. Is the audio going?
Yes, sir. Yes, sir, you are audible.
Can you hear me well? Can you hear me
Yes,
well?
sir.
Okay.
Yes, sir.
Okay. Okay. Now what happens is that if you have a high FSH and you have an high LH and a low testosterone, it basically means primary testicular failure. If you have a low FSH, low LH, low testosterone, it means hypogonadotrophic hypogonadism. And if you have a normal FSH, high LH, high testosterone, it basically means there is some problem which is happening with the LH secretion. You could have a normal FSH, normal LH and a normal testosterone, which is fine, normal. But you've got to judge it along with the clinical size of the testes, the history of the patient, and the examination and the epididymis of the patient. But मोटा मोटा अगर मैं कहूँ, आप किसी भी पेशेंट में अगर टेस्ट कराने हैं, लो स्पर्म काउंट है, एजोस्पर्मिया है, you get an FSH, LH and testosterone done. तो लिटरेचर में से FSH and testosterone, but let me be honest, LH doesn't cost much. So you might as well get it done. In a few patients, if they are obese, get an E2 done. And in case they have a history where they say they also have a sexual problem, get a prolactin done. And one test which is very useful and very cheap is a TSH. Get that done as well. So scrotal ultrasound, see, the interesting thing about the testes is that testes are hanging out. You can actually examine them. You don't need an ultrasound for that. But you need an ultrasound in case you want a documentation of confirmation of the varicocele, or you feel that there is any focal calcification, tumor, epididymal cyst, and in case the testes are pulled up, you may get it done. See, a postcoital test used to be done a lot and it is very useful, but the main use of a postcoital test is to understand that they actually have intercourse and the effectiveness of this intercourse. So now I won't talk of too many investigations now, but I'll just show you something about the examination. Now, when you examine a testes, now in the both the testes, you're going to see the consistency, you would like to see the size, and you would like to see the epididymis and the vas. So just see over here. Over here, you will see the testes, the epididymis on an ultrasound. So I routinely do ultrasound of these patients. So you like to do this, you'd like to see the veins, you'd like to see a varicocele. But in a testes mainly, you'd like to see the testes, the architecture of the testes, the parenchyma, and to rule out if there is any abnormality in the parenchyma. Now, examination of the epididymis is most important. Now, why is examination of the epididymis important? Because you want to see the head, body and tail of epididymis. See, between my fingers is the epididymis. Can you see it? Yeah. So you'd like to examine the epididymis, and if you see close by, oh sorry, yeah, just wait please, huh? So this is the epididymis. Can you see the epididymis over here? This is examination of the epididymis, and let me show you how it appears in the ultrasound. This is the epididymis in the ultrasound. This, can you see this epididymis?
Yes, sir.
So this is very, very interestingly seen in ultrasound. And since I do my ultrasounds myself, though I really don't have time the whole day because these are so many things I love to do. So after you've examined, in case you do an ultrasound, it gives you an idea, especially in the azoospermics, that what are you expecting? What are the chances that it probably could be an obstructive azoospermia? Now let me come to the next slide, which is the VAS. So I'm trying to feel the VAS between both my fingers, the finger behind and over here. And I'll show you how a VAS looks. See this. This is how a VAS looks on ultrasound. So you like to feel the VAS because that's very important for us to feel. Now, examination of a varicocele. So varicocele is normally seen in a standing up position. It will be in a standing up position so that the pressure of veins may be there, and you'd like to examine the varicocele first without a valsalva and then with a valsalva. Now see over here. This is how a varicocele appears. Now the moment you will give a valsalva, just look at this flushing, and there may even be a reversal of flow. So this is quite diagnostic of a varicocele along with the size of the veins. Now I'd like to talk about some functional tests. So we've spoken about a semen analysis. We have spoken about the examination which I have shown to you. So beyond numbers, we'll talk about the functions. So there are basically three areas which I could talk to you about. Number one is sperm DNA fragmentation. Number two is oxidative stress testing. Number three is epigenetics and transcriptonic profiling. Now this is emerging. So in the first one, which is the DNA fragmentation, now this is one of the most cited papers in the world, sperm DNA fragmentation, a new guideline for clinicians, of which I was a part of. Now if you ask me very honestly, a high DFI leads to poor ICSI outcomes and increased miscarriages. Now sperm with a high DNA damage can look normal morphologically, but there could be a high DNA fragmentation. Now, testicular sperms often have a lower DFI. These are three things for us to understand because the semen count may appear to be normal, and that normal semen count you may feel everything is fine, but the functional capacity of these sperms is not good. Now, let me talk about sperm DNA fragmentation. The causes could be reactive oxygen species. It could be advanced paternal age. It could be a varicocele. It could be lifestyle factors. How do you test it? There are a lot of tests: SCSS, sperm chromatin structure assay, tunnel. You could have sperm chromatin dispersion, comet assays. But the most commonly used is the halo test, or a test in which there is fragmentation which is seen on the halo, which is seen on the microscope after staining. Now, when will you test SDF? Now, this is for every gynecologist. Any unexplained infertility. If there are IVF failures and if there are recurrent pregnancy losses. What is the impact of a high DFI? Fertilization rates are lower. Miscarriage rates are higher. ART success is less. And IVF success is very low. ICSI, it is better because in ICSI, when you place a high DFI sperm into the cytoplasm, number one, the injury which takes place outside in an IVF doesn't take place. Number two, in case repair needs to be done, the cytoplasm of the egg can repair it as soon as possible. And this is the reason in poor sperms, A young egg of a younger woman is much better, and the results are much better than an older egg because of the repair of the sperm. Now, how do you manage high SDF? Three basic things: lifestyle changes, smoking alcohol to be closed, better food, antioxidants, 3 to 6 months targeted supplements, and frequent ejaculations, because the more the stoppage of ejaculation, the more the DNA fragmentation. Now, what are the advanced techniques? PIXI, MAX, microfluidics. Now, in PIXI, what do you do? In PIXI, you basically see the binding to the hyaluronic acid, and that's what physiologically would appear to be better sperms. What would you do in MAX? Now, magnetic activated cell sorting for selected non-apoptic sperms. And in microfluidics, you select based on motility and morphology. All these are experimental. Show promise, will take some time, need validation. Now, this is a very interesting slide, and I was again a part of this whole study: male oxidative stress infertility. Data of, I would say, 2014. So in 2014, there were 186 million infertile couples, 50% women, 30% both, 20% man. So male factor actually was 50%, which is about 93, but 100 million, I would say, much more now. So if you consider the known factors, they are 50%, so 50 million. And idiopathic, where nothing is found, about 50 million. And can you imagine that in the people where there was a known factor, oxidative stress was in 30 to 40%, and in idiopathic it was about 80% oxidative stress. This led to coining of the term by my dear friend Dr. Ashok Agarwal, MOSI, male oxidative stress infertility. Now, what's the rationale? The rationale of any antioxidant is to improve the sperm parameters, motility, morphology, and prevent the oxidative damage. So, what are the common agents used? Coenzyme Q10, L-carnitine, vitamin E and C, and zinc. Now, when to use? Idiopathic OAT, high ROS, high DFI, give for at least 3 to 6 months. Now, idiopathic either he is an idiot or the doctor is an idiot. They don't understand what's the reason. But they don't realize that people don't realize that the prevalence is 30 to 40%. And the management is empirical treatment combined with appropriate ART planning. Now, what could you do in lifestyle? So, they need to reduce their weight. You need BMI optimization, regular exercise, smoking needs to be stopped, reduced alcohol, and to avoid any toxins. What therapies are available? So you have antioxidants, 3 to 6 months trial for idiopathic OAT, clomiphene if there is low or normal testosterone, letrozole if there is high estradiol, and FSH in very, very selected and less cases. Very selected cases. Now, the role of antioxidants, see what happens is I'll tell you about these four. Coenzyme Q10 improves mitochondrial function and energy production. L-carnitine is the transporter of fatty acids to the mitochondria, and therefore it enhances sperm motility and maturation. You'll be surprised to know that the maximum level of carnitine is present in the testes and the epididymis. Next, omega-3 fatty acids, they reduce inflammation and improve the membrane integrity. And lycopene, of course, is a powerful antioxidant that reduces oxidative damage. Now, what are the infections which they could do? So, you could have a prostatitis, you could have a sexually transmitted infection, you could have epididymitis. And what do? They lead to reactive oxygen species obstruction and inflammation. Now, how do you diagnose? infection. Semen culture. If the leukocytes are more than 1 million per ml, it indicates infection. So you could do a culture, or at times for specific detection, you could use a PCR. Now, treatment. Targeted antibiotics treat both the partners, give anti-inflammatories. The most commonly used, I would say, antibiotic by me normally would be a quinolone along with doxycycline, to be taken for minimum 3 weeks till 6 weeks. Most important thing, don't overuse antibiotics. Treat confirmed infections, and infection clearance does not guarantee fertility. Remember this. Hormones, in hypogonadotrophic hypogonadism, you could use them, and you could use them if there is a testicular and estrogen imbalance. So what you need to get done? You need to get done a hormonal profile. If the LH and FSH are low, as in Kallmann syndrome pituitary tumors, you could give them HCG 1500 to 3000 IU 2 to 3 times per week. Now what does it do? It stimulates the Leydig cells to produce testosterone. And you could add FSH 75 to 150 IU 3 times a week to stimulate the spermatogenesis. Now how will you monitor the progress? By semen analysis every 3 months and adjust the dose accordingly. Now clomiphene, you would give it to patients who have borderline testosterone. Aromatase inhibitors, you'll give where the TE ratio is not correct. Obese men, because they act as primarily aromatase inhibitors to decrease the conversion of testosterone into estrogen, and the testosterone increases. Prolactin disorders, again, need to be treated by caberlin and bromocriptine. But remember one small thing. Never give testosterone to a man who wants a baby. The moment you give this, you know what happens? There is testosterone floating in the blood. The brain says there is adequate testosterone. LH goes down. Testosterone production goes down in the testes. And to make sperms, what you actually need is intratesticular testosterone, which goes down whenever you give external testosterone. So please never give any kind of testosterone. If any testosterone is given, please stop it. Now, post-steroid recovery. Now, I get a lot of patients who come from gyms. Just stop all steroids. You may need to give some things like clomiphene or SCG. That depends on how the patient is. You basically need to bring them back to where they belong to. Now, ART decision timing is most important. So, whenever you see male infertility, you have to be very, very cautious about the age of the woman and plan everything accordingly. So, please don't delay ART, which means supposing there's a man who is there with a poor sperm count and the wife's age is 35, AMH is low. So you just can't sit down and think you'll start treating this patient and this male for a long time. So the gap time needs to be very important and you've got to be very cautious about it. So ART role, IUI mild to male factor, IVF for moderate, ICSI for severe factor. Now hypogonadism, I've told you, treatable condition to 20% success rate, conception rates. A lot of people may get pregnant naturally or with minimal ART intervention. So in summary, you've got to do the history and evaluation, address infection and lifestyle, do hormonal optimization, give them antioxidants, and DNA integrity needs to be maintained if needed, and then proceed to either ART or sperm retrieval. So I've referred to and I've brought in a lot of professional organization papers into this and some key studies about which I have spoken over here. So go on to the second presentation, which I'll kind of finish in the next 20 minutes because it will be 1 hour then. And so I'm going to talk about the next presentation. So surgery. So knife needle microscope. Surgery adds value to male infertility. I'm going to talk about a few retrieval techniques, and I'm going to tell you how to make a better ART pathway by surgery. Azoospermia, 3 patients I've got. One is Mr. Anand, 35 years old, vasectomy did 5 years back, normal testes. Second is Mr. Bhavesh, 32 years old, suspected epididymal obstruction. And third is Mr. Chirag, 30 years, small testes, high FSH, non-obstructive azoospermia. Now, why operate in the ICSI era? Great question. But interesting answer. Male factor is equal to 50% infertility. Azoospermia is 1% and 10 to 15% of infertile men. ICSI needs very few sperms, but sperms require surgery for retrieval. Can surgery avoid ART in some? Can surgery reduce number cost of ART cycles? And the answer is yes. So first, let me talk about obstructive azoospermia, non-obstructive azoospermia. Non-obstructive azoospermia, you'll have small testes, high FSH. Obstructive, you'll have normal testes, normal FSH. Examine, see the clinical examination, see the volume. Now, depending on that, you'll make a decision of what you need to do. So, PISA, you're going to put in a needle inside the epididymis to take out sperms. You could do it local OPT procedure. TISA, you put a needle in the testes. People misuse this procedure a lot because if you have not got in a PISA, the chances you'll get in a TISA are very low. And for for non-obstructive azoospermia, it literally has no role. TISA is taking out a small biopsy, which is better than TISA. But the gold standard again is micro TISA and MISA. MISA is used. So MISA, what you do is you open up the epididymis under a microscope. See it under a microscope, so the retrieval and the amount of sperm you get is much higher in obstructive azoospermia. So it is microscopic epididymal sperm aspiration. And then you have micro TISA. Now this is the gold standard for non-obstructive azoospermia, and this is the best for non-obstructive azoospermia. So I'll just talk to you about a few things. So whenever you are doing a micro TISA, you need to have some methodology by which you could be in direct contact with your embryologist. And the question is whether you do a unilateral or bilateral. If you've not found sperms in one, you're going to open the second one. And you need an intraoperative biologist. PISA, TISA. Now let's just see how PISA is done. So you're going to take a butterfly, place a 5 ml syringe, have some media in the tube, put the needle into the epididymis, give a suction, clamp the tube, pull out the needle, and the aspirate is then placed. This is a PISA. Next is conventional TISA. Now this is a very small surgical approach which I am trying to show you here. So this is a window kind of an approach where you take a small biopsy. So tissue requirement, however, is quite a bit because there's a lot of tissue which comes out even in a small biopsy. Now I'm going to talk to you about FNA mapping. So this is very interesting because what you do over here is in the testes, 8 points above and 8 points below, you put in a thick needle, 16 gauge, give pressure with a 20 or a 10 ml syringe, pull it out. When you pull it out, a tubule comes out. You take a microforceps and just start pulling the tubule. So what you actually get is quite an amount of tissue. So this is the way you would normally take out some tissue. In case you get any sperms in this, you know where they are, and even they could be sufficient. So before micro TSA, you could do this procedure. Now, let me show you what happens in a micro TSA. So in a micro TSA, what you actually do is open up the testes, and in the first plane, under a microscope, start taking out the tubules which you feel are thicker and could be having sperms. Now see over here. If you see over here, all these are thin tubules. But this is an area which has thicker tubules. Can you see this area? This one, the one above it. Yes. Now these are the tubules which could be having sperms. I'm giving you and showing you a differentiating area, the way it appears to be. See here. So if you see over here, these are thicker tubules, and see below that, they're very thin tubules. So these are the kind of tubules which are going to have sperms.
ওই একজনের গপ্প দিয়ে কি হবে, সবার সঙ্গে এরকম হয় না গো।
Okay, so that's the way they are. So this is the kind of tubules you're going to pick up. Now just see the tissue requirement. In a micro TSA, a very big advantage is very little tissue is needed compared to conventional. And therefore what happens is the reduction in testosterone is very less post-surgical. Now what do you do in the laboratory? You got to have it temperature controlled, and you normally would do mechanical mincing. If blood is there, we don't remove it because we get an outline in the RBCs of sperms, as you can see over here, and it gives us a background to find out sperms, which we normally would be using. So if you see over here, you would normally see that we would be finding sperms. To pick them up in this background. So once you get a sperm, just see this. You would go ahead and do an ICSI with this. So you could do a sperm enrichment, but normally in non-obstructive azoospermia, we get such few sperms that the question of really enrichment is not there. So it is a question of finding these sperms, seeing which is the best you can find out of them. At times the number of sperms we get is very less, and inject them into the cytoplasm of the egg. Now MESA is a technique in which microscopically from the epididymis we get a lot of sperms. Now before we do a micro TSA, we've got to optimize by giving at times SCG to bring up the testosterone. We've got to do an endocrine assessment, stop any anabolic steroids, manage obesity, heat exposure, and coordinate with the team on fresh and frozen strategy. Normally non-obstructive azoospermia, it is best to use fresh if possible, because the number of sperms you get is less, and it is best to use the fresh. Now intraoperatively, you need a real lab biofeedback and stop when the sperm you got is adequate. You need a very gentle tissue handling, and histology of non-obstructive specimens should be done. Biopsy should be. Postoperatively, scrotal support, infection prophylaxis when needed. Check testosterone at 3 to 6 months after extensive TSA and micro TSA. Now, success is dependent on the surgical technique, the lab quality, and the patient selection. And along with that, how much patience you have to do this procedure. Now, varicocele, when will you do? If there is a clinical varicocele, abnormal semen, infertile couples, sometimes high DNA fragmentation or recurrent ART failure. Now, it improves the quality of the sperm and at times the count and motility. So you need a microscopic varicocelectomy because you've got to save the spermatic artery. See this. See this over here. Can you see the pulsation over here? This is the spermatic artery, which you normally will see only under a microscope. You can't see the pulsations otherwise. And this spermatic artery needs to be saved. It is behind it. This is the vein. Now, reconstructive vasovasostomy, vasoepididymismy, turette. So you've got to select a case. Like in the first one, vasovasostomy and MESA could be done if the age of the partner is less. In the second one, probably aspiration would have been better if MESA is not possible, vasoepididymostomy is not possible. So I'll come to the 5 pearls: obstructive vasospasmia, non-obstructive vasospasmia. Think before you're going in where you're going. Try something minimal invasive first. You should have very good protocols when it comes to surgical sperm retrieval. It's a tough job. It's a difficult job, both for the embryologist and the surgeon. So you've got to be very clear where you are. क्योंकि जब तक आपको मालूम नहीं होगा, आप पहुंचोगे कैसे? Strategic reconstruction, especially varicocelectomy or reconstructive surgery, needs doing good microsurgery. And you've got to be very clear in the expectations you set in non-obstructive vasospasmia. And your counseling should be very important initially itself. And you should include endocrine follow-up if you can get it done. And along with that, you need a plan B. So good male infertility surgery is not about a bigger operation. It's about smarter choices. So we've been doing it for a very long time now. And we've realized that we could probably retrieve sperms in 70% with a live birth rate which can be good and very less complication rates. In the end, I'll say thank you very much for being here. And I've tried to summarize everything in the short time which I could. It's not short, I've been speaking for 50 minutes now. So I've summarized it in 50 minutes. If there are any questions in the next 10 minutes, I'd love to answer.
Thank you, sir. It was very excellent presentation, and I do have a question. Can I ask?
Please.
Sir, in non-obstructive vasospasmia, so before proceeding for surgical sperm retrieval, do you routinely give FSH, LH?
No. I only give LH. See, if I could clear something with you guys over here. See, you never give LH unnecessarily to a man. If his testosterone is normal and LH is normal, there is no medical sense. There is no, I would say, common sense of giving the man HCG. But in case the testosterone is low and the LH is borderline, then you would give these patients HCG, and that is the role of HCG. Now the question of giving FSH. Normally these non-obstructive vasospasmia already have a very high FSH. By giving them FSH, what are you doing? You're doing nothing. So I normally would like to bring the testosterone up. 3 medicines I use for that. I'll tell you everything. Number 1, you would use clomiphene in case the testosterone is borderline. It's a good drug, can be used. In case the estrogen is high, I would use letrozole. And in case the LH appears to be low, and in case I feel that the response will be good and the testosterone is down with the low testosterone, I'm going to give these patients HCG. That's what I do.
Sir, regarding scrotal ultrasound in all patients of non-obstructive vasospasmia or you do scrotal ultrasound in which selective patient?
I don't. See, I do my ultrasounds myself. So in an obstructive vasospasmia, I normally would do to see the seminal vesicle, the way the vas is. I'd like to see the turgidity of the epididymis. I'd like to see the blood flow of the epididymis. And that gives me a fair idea about the retrieval and the chances of retrieval and what I would do. So I use this as an adjunct. You see the testes is lying outside. You can feel it with your fingers. So why put an ultrasound probe unless and until there is something specially you want to see, like the architecture of the testes, the architecture of the epididymis. So these are the conditions I would use it in. But it is not necessary to do an ultrasound in a non-obstructive azoospermia. You got to feel and you'll know the volume. You'll feel the epididymis, you'll know. But I want to see the eco texture because I do all the things myself, in the sense I would examine, I would do an ultrasound. Then when I do a sperm retrieval, I get an idea. Then with the embryologist, I would understand what is happening. So that's the way it is.
Are there any more questions from the audience? Sir, can I ask one more questions?
You can ask any number of questions.
So, what is your take on the role of karyotyping in the male partner if it is severe oligoastheno? Do you routinely
What to
do?
be done? Any person with a sperm count less than 5 million or 2 million, you've got to do a karyotyping and a Y chromosome microdeletion. The reason is simple. In karyotyping, at times, even in a plain karyotyping, you get a lot of patients in whom you would probably get any kind of translocations. Robertsonian translocations, balanced, unbalanced, are very common. So you've got to be very, very clear when you counsel your patients, because in case there is a balanced translocation, it is transmissible in a particular section of the offspring. And the second thing is, if there's a Y chromosome microdeletion, if it is in the A and B area, you won't get a sperm. So why do a retrieval? And in C, you may get a sperm, but the child, if it is a male, will have the same problem. So you've got to counsel them. So therefore, it is very important to do this.
Are there any more questions from the audience? Sir, do you routinely do sperm DNA fragmentation? I mean, if there is a sperm DNA fragmentation, then also the treatment will be same. And if we generally also prescribe those lifestyle changes and antioxidants, so
See, you've got to, very simple in medicine, you've got to document things. And it's not the same actually. It's, you won't do a DNA fragmentation in every patient. Unexplained infertility, you'll not be able to explain. You've not seen endometritis, you've not seen the endometrium, you've not seen the blood flow of the uterus. You've not actually done a laparoscopy if it was required to see if there is grade 1 endometriosis. And you've not done a DNA fragmentation. And you've labeled the person as unexplained. No, not justified. Number one. Number two, pregnant pregnancy failure. Number three, failed IVF. Why? Because ICSI is a better procedure. Number four, it is not necessary that if you give antioxidants to people who have sperm DNA fragmentation, it'll be okay. I mean, it's not I would say it's not crocin. A few people may improve, a few people may not improve. So it's very important to do a DNA fragmentation before and after to even compare things. It's a very simple test. So it's not a problem at all. And the second important thing is you read that article, that clinical article, which is their clinical guidelines. It's a beautiful article and it's not very big either. So you read that, you'll really realize how important it is. How important it is for you to do a DNA fragmentation in patients. You have a patient of varicocele. Sperm count is normal. Wife is fine. Varicocele grade 2, grade 3. Will you operate? Get a DNA fragmentation done. After varicocelity, it will improve. Patient has pus cells. You give an antibiotics. You think it's okay. Pus cells have decreased. Just do a DNA fragmentation and see what has been the result of the ROS before and after. I mean the oxidation before and after. So it's very important to understand and judge everything in sync. I mean, one thing leads to the other. So DNA fragmentation is a very important test which helps in a lot of places, needs to be done, and is very helpful at times.
thank you, sir. Thank you so much for your presentation. And I hope for everyone also this talk has improved their knowledge on male infertility. And
So thank you very much. Thank you very much, everybody.